Welcome to the Lecturio Podcast. Today we're doing a really critical deep dive, one that's specifically for you nursing students. We are going to be exploring the kidneys.
The body superheroes.
The mighty superheroes,
Yeah.
for sure. And our mission today is pretty clear. First, we'll build that core anatomical foundation, what they're made of. And then we jump straight into the clinical side mastering how to interpret the four main renal function tests.
Right.
So this is all about going from the textbook to confidently assessing your patient's kidney health.
And that confidence is just so crucial because as a nurse, you carry a huge amount of accountability here. Being able to spot the risks for acute kidney injury, we call it AKI. Sometimes you'll see ARF or even chronic renal disease, CRD. It's just paramount. These things can be so silent at first.
So the labs are our first clue.
They're often the only clue. And finding it early lets us intervene fast, and that is often the only way we can slow things down and, prevent a real catastrophe.
Okay, so let's break this down from the beginning. The job we all think of first is, well, filtration. The kidneys are filtering your blood all day, every day.
Multiple times a day, yeah.
Pulling out nitrogenous waste like urea and creatinine, balancing water, and then, making urine. But calling them just a filter, it really sells them short.
Oh, it really does. I mean, think of them less as a filter and more like the body's master chemists. They're juggling like 6 critical functions all at the same time.
Okay.
The first one is what you just touched on, cleaning and maintaining the extracellular fluid, or ECF. That's the fluid, that's bathing all of your cells. It's just fundamental for keeping them alive.
That's kind of the volume control piece.
That's the volume control. The second big job is maintaining that super delicate acid-base balance. When you get to arterial blood gases, you'll see the kidneys are the long-term players, carefully managing bicarbonate to keep blood pH in that tight little window of 7.35 to 7.45.
So important.
Then the third one is waste excretion, of course, but also, and this is critical for nursing foreign substances, that includes most of the drugs we administer.
Which is why we see so many dose adjustments in patients with renal failure. That suddenly clicks into place. But they're also tied into cardiovascular health, aren't they?
Oh, very directly. That's their fourth superpower, regulating blood pressure. We can talk more about that when we get to their hormones. But before that, function number 5, reabsorption.
Right. People focus so much on the filtering part.
They do, but filtration is kind of useless if you just throw out all the good stuff with the bad.
And this is where the sheer scale of their work is just... it's mind-boggling.
It really is. They filter these huge volumes of fluid, but then they pull back almost everything vital: water, glucose, amino acids. Something like 65 to 70% of everything they filter gets reabsorbed right back into your circulation.
65 to 70%. That's an incredible number.
It's a recovery system, not just a waste disposal chute.
So that means that all that microscopic machinery in the nephron, you're talking the glomerulus, Bowman's capsule, all those winding tubules, they're doing some serious work. So if the proximal convoluted tubule, the PCT, handles most of that reabsorption, where does the loop of Henle fit in?
That's a great question. The PCT is like the bulk reclaimer, right? It just grabs all the essentials. The loop of Henle and the collecting ducts, they're the concentration specialists.
Okay.
Their job is to fine-tune, to make sure the final urine is either really concentrated or really dilute, all depending on how hydrated you are. It's how we avoid, peeing out gallons of water every hour.
And that leaves us with the 6th function, the one that I think gets missed a lot because it isn't about filtration at all.
It's hormone production. The kidneys are endocrine organs. They make renin, which kicks off the whole renin-angiotensin-aldosterone system for blood pressure.
A huge one.
Huge. They make erythropoietin, or EPO, which tells your bone marrow to make red blood cells. That's why chronic kidney patients are almost always anemic. And then they activate vitamin D into calcitriol, which you need for calcium absorption and healthy bones.
Wow. So one failing organ immediately creates 3 huge nursing challenges: managing blood pressure, managing anemia, and managing bone health.
That's all connected.
All connected. So before we get to the lab tests, let's connect this physiology to the actual patient. What are the signs that should make a nurse think, okay, I need to do a deep renal assessment right now?
Well, beyond just general fatigue, you're looking for peripheral edema, swelling, unexplained hypertension, and then the signs of uremia. That just means waste products are building up in the blood.
And what does that look like in a person?
Patients will often complain of confusion, nausea, maybe a weird metallic taste in their mouth, and sometimes really severe itching, what we call pruritus. Those are all screaming that something is wrong with the kidneys.
Okay, that is the perfect transition to the practical side of this. Part 2, deciphering renal function tests.
This is where the rubber meets the road. We're using blood urea nitrogen, or BUN, serum creatinine, eGFR, and urinalysis to find those silent clues.
Let's start with BUN. So urea is that nitrogen-containing waste. If the kidneys are healthy, they filter it out. So if the level in the blood is high, the kidneys aren't working well. What's the normal range?
We're looking for about 7 to 20 milligrams per deciliter. But the real practical tip here for nurses is that BUN is a dual indicator. It tells you about renal health, but also liver health.
Right, you mentioned the liver is where urea is actually made.
Hmm.
Why is that connection so important to remember?
It's all about that nitrogen waste cycle. So when your liver breaks down protein, it produces ammonia as a waste product. And ammonia is incredibly neurotoxic.
Dangerous stuff.
Very. So the liver's job is to convert that toxic ammonia into the much safer, less toxic urea. So if the liver is failing, it can't make urea. If the kidneys are failing, they can't get rid of the urea. You have to look at both.
Okay, let me ask a clinical context question here. What if you have a patient who is, say, malnourished or on a really low protein diet? Could that give you a falsely low BUN and maybe mask a real kidney problem?
That is an excellent point, and it's precisely the challenge. Because BUN production depends on protein, a low protein state can definitely push that number down. It can give you this false sense of security.
I see.
And that's exactly why we never, ever look at BUN in isolation. We always pair it with its more reliable partner, serum creatinine.
The perfect segue. Let's talk creatinine. This is a waste product from muscle metabolism. So what makes it a better, more stable indicator than BUN?
Well, creatinine production is pretty constant. It's directly related to a person's muscle mass, and unlike urea, it isn't really affected by your diet or hydration in the short term.
So it's a cleaner signal.
It's a much cleaner signal. Healthy kidneys filter it out efficiently, so if your kidneys are impaired, that number goes up. It's so reliable, in fact, that it's the main variable we use to estimate GFR.
And the normal range for that is pretty tight, isn't it?
Very tight, usually around 0.5 to 1.2 milligrams per deciliter. And even a small jump, say from 0.8 to 1.4, that's a huge alarm bell that something is wrong with the kidneys.
But as you said, high creatinine isn't always chronic kidney disease. There are other causes. How do we tell the difference between true kidney failure and something like, say, dehydration?
This is where we use the BUN to creatinine ratio. It's a great tool. In a healthy person, the ratio is maybe 10 to 1 or 15 to 1.
Okay.
But if you see that ratio jump up, say, over 20 to 1, that strongly suggests a pre-renal problem. Most of the time, that's severe dehydration. The kidneys themselves are fine, but they aren't getting enough blood flow.
And if the ratio is normal, but both numbers are high?
Then you're looking more at intrinsic kidney damage, true renal failure. That ratio is a core part of your assessment.
That ratio is a fantastic tip.
Okay.
Now let's move on to the big one, the ultimate report card. The glomerular filtration rate, or GFR.
Right. So the GFR is basically measuring how well the filtering units are actually working. But measuring it directly is really complicated, so we use an estimated GFR, the eGFR, which is calculated from that serum creatinine level plus age, sex, and body size.
What's the number we're looking for in a healthy adult?
So a normal eGFR is usually just reported as being greater than 90. But here's the key thing you'll see in practice. The lab often won't even report an actual number until the reading drops below 60.
Below 60. Why is 60 the magic number where the alarms really go off?
Because 60 is generally the line where we start diagnosing chronic kidney disease, CKD. And it's at that stage where all those complications we talked about, the anemia, the high blood pressure, the bone issues, they really start to show up and need active management.
So how do providers use that GFR number to stage the severity of CKD?
It's pretty straightforward. A GFR between 60 and 89 is considered mild CKD. Once you get down to 45 to 59, that's moderate CKD or stage 3A.
And that's a big deal.
It's a very big deal. Stage 3 is where you have to start aggressively managing things like phosphorus and calcium. Then 15 to 29 is severe CKD, and anything under 15 is end-stage kidney disease, which usually means dialysis or transplant is needed.
So GFR is fantastic for tracking how bad the disease is, but you mentioned it doesn't tell us why it's happening. For that, we need our last tool, urinalysis.
Exactly. Urinalysis is fantastic for screening for UTIs, diabetes, and for pinpointing the source of the kidney damage. The nurse's job here is really about getting a good quality sample, a clean catch, or maybe that first, more concentrated morning sample.
The first report gives us the basics, pH, and so on. But where does the real detective work happen?
That happens in the microscopic sediment exam. The sample gets spun down in a centrifuge to concentrate everything at the bottom: cells, crystals, bacteria, and these things called casts. Looking at that sediment under microscope can give us very specific clues.
Okay, so what are the red flags we're looking for that point to something serious, like glomerulonephritis?
You're looking for blood, either visible or microscopic. A big increase in protein is another major one. But the most specific findings are casts. You can think of a cast as a tiny little mold of the inside of a tubule. It forms when protein or cells clump together and harden inside the nephron.
The mold of the tubule. So if you find a red blood cell cast, what does that tell you?
Finding a red blood cell cast is the smoking gun for acute glomerulonephritis. It tells you with almost total certainty that the bleeding is happening way up high, inside the glomerulus itself.
Wow.
Yeah. And similarly, finding white blood cell casts points towards an infection or inflammation right inside the kidney. These casts are what help us tell the difference between a simple bladder infection and serious kidney damage.
And that is really the critical contrast, isn't it?
Mhm.
You have the obvious symptoms a patient reports, like flank pain or blood they can see in their urine, versus these silent asymptomatic signs that only the labs can show you. The subtle change in a ratio, a creeping creatinine, or these specific casts in the urine. That's the core of early nursing assessment.
That's it exactly. Your job is to catch those silent signs before the damage becomes irreversible. And really mastering these 4 tests gives you the power to do that.
That was an incredibly helpful and practical deep dive. So to recap quickly for everyone, remember those 6 key functions of the kidney, especially that hormonal control over blood pressure and red blood cells. And your 4 go-to lab tools are BUN, serum creatinine, GFR, and a thorough urinalysis.
And always use that BUN creatinine ratio to give you context.
Yes, absolutely.
Understanding the story these numbers are telling you about your patient's body, that's what's vital for providing safe care. Always focus on the why behind the number. If you keep building on this knowledge base, keep learning with great resources like Lecturio, you'll be well on your way to becoming a fantastic, critically thinking nurse.
Thank you for joining us for this crucial deep dive. We'll catch you next time.